Before we proceed with the part 2 of this lecture, here is a quick revision. So by looking at this diagram, can you tell me which one is an agonist, which one is an antagonist, and the inverse agonist? Well, this one is an agonist. In other words, an agonist will always increase the response from a receptor, so it is positive, while an antagonist blocks the response from a receptor, so it is neutral or zero, while an inverse agonist decreases the response from a receptor, so it is negative. So we can then design drugs based on the type of responses that we want to generate. To treat allergy, we can use the H1 antagonist. So what it does is to block the H1 receptor so that no histamine can bind onto it. And they come in 3 flavors or 3 generations. So the first generation antihistamine is not very selective for the H1 receptor because they can also bind to the muscarinic acetylcholine receptor. And for this reason, patients will encounter side effects like difficulty in urination and a dry mouth. So these drugs are not very well tolerated because they can cause massive drowsiness. And one classic example of the first generation drugs is diphenhydramine as mentioned just now. And because of its side effects, we actually use it to treat motion sickness such as vertigo or nausea. And then another drawback for the first generation drug is that they have a relatively short lifespan, which is around 7 hours for diphenhydramine. And so you will need to take at least 3 doses per day. Then you have the second generation antihistamine, which is less sedative and have fewer side effects. It is less sedative because these molecules are hydrophilic and therefore they cannot cross our blood-brain barrier, which is a membrane that is hydrophobic. So examples of second generation drugs are like cetirizine and terfenadine. So cetirizine is actually an inverse agonist, so it reverses the effect of the H1 receptor. So it's a stronger drug than the antagonist, and it also has a shorter lifespan of about 10 hours. Terfenadine, on the other hand, have been withdrawn from the market because it is toxic to the heart. But look at its half-life. It is about 20 hours. So how many times do you have to take this drug in a day? Well, just once. And now we have the third generation drugs, which is a controversial term to use because these are basically the active metabolites from the second generation drugs. So these are preferable drugs because they have less cardiac toxicity, which means they tend not to affect your cardiac function. For example, you have fexofenadine, which is an active metabolite produced from the terfenadine. So look at how this methyl group is being replaced by a carboxylic group over here. So with this change, you get less of the side effects, but also a shorter lifespan. Again, terfenadine is cardiotoxic because it can lead to arrhythmia or irregular heartbeats and heart attack at high doses, as it can block our potassium channel in the cardiac tissue. And it is especially dangerous if we eat terfenadine together with other drugs such as macrolides, which is a class of antibiotics, ketoconazole, which is an antifungal drug, or even grapefruit juice. But why is it so? That's because these compounds are the inhibitors for the cytochrome P450 system, and it's a system that we rely on to remove toxic compounds from our body. So with such inhibition, you can expect that terfenadine will take a longer time to be removed from our body, and as a result, it can cause heart attack. So for this reason, we no longer use terfenadine, but fexofenadine, which is an active metabolite of terfenadine converted by this enzyme CYP3A4. So based on the side effects of the H1 antagonists, we can use them to treat other illnesses such as insomnia, because the first generation H1 antagonist is a strong sedative drug such as promethazine. On the other hand, they are also antiemetics, meaning that they can treat motion sickness such as cyclizine. So in short, antihistamine isn't just for allergy, but they have other functions and uses. And next, we'll look at the role of histamine in regulating gastric secretion, and that happens through the H2 histamine receptors. Before we proceed, here is a question. Which type of acid is in the gastric juice? Well, the answer is C, HCl, or the hydrochloric acid. Because it is a strong acid, you will have a gastric pH around pH 1 to 3. And just how much gastric acid is produced every day? Well, the answer is D, 1.5 to 2.5 liter, which perhaps is more than the water you drink every day. So, gastric acid is secreted by the parietal cell found on the surface of your stomach lining. And the mediators that boost the production of gastric acid are histamine, gastrin, and acetylcholine. So you should know what is histamine by now, while for gastrin, it is a small peptide hormone that is secreted by the G cell. As for acetylcholine, it is a neurotransmitter. But how does it work? So in this diagram, what you have in the middle is the parietal cell. On your left, you have blood vessel along with the plasma, while on your right, you have the lumen of the stomach. So to make HCl, what do you need? You need both protons and the chloride ions, right? So we can get protons from the breakdown of the carbonic acid. So that will be done by the enzyme carbonic anhydrase. And then the proton can be pumped out by the proton pump into the lumen. But as we pump out the positively charged proton, we have to bring in the positively charged potassium to balance the charges. Now, on the other hand, how about the bicarbonate ions, which is the breakdown product of the carbonic acid? Well, they are excreted out of the cell by an antipod or antiporter protein. Again, to balance the charges, we have to import the negatively charged chloride ions by the same antiporter protein. So it is called an antiporter because it transports two different substances at the opposite directions. And with that, you have got the chloride ions which can be secreted into the lumen by the syn-pod carrier. So it is known as a syn-pod carrier because it transports two different substances onto the same directions, which in this case are both of your chloride ions and the potassium ions. So we all know that gastric acid can lead to gastric or peptic ulcer. But the major cause of peptic ulcer is actually bacterial infection. And the bacteria is Helicobacter pylori. It is called helical because it has all these helical flagella. And over here you can see the bacteria as the dark entities inside your stomach lining. And they are making holes on your stomach. So that is a serious condition. So as acid penetrates your abdomen or peritoneum, you can get a systemic infection, or we call it sepsis. And according to many research, H. pylori infection can also increase your chance of getting the gastric cancer. So how do we cure or treat H. pylori infection? Well, the first strategy was developed in 1970s by using the H2 histamine antagonist. So this treatment reduces gastric acid production, but it does not kill any bacteria at all. As expected, you will need many rounds of treatment and the disease is never cured. While the real treatment came in 1987, which is known as the triple therapy, since it contains three components. First, you have the conventional H2 antagonist, followed by a combination of antibiotics and bismuth. So bismuth is toxic to H. pylori and it has protective effects towards our stomach lining. But today, we are using PPI, which stands for proton pump inhibitors. They will reduce gastric production. That's because H2 antagonist has many side effects such as thrombocytopenia or a low platelet count and arrhythmia, which means irregular heartbeat. But the use of PPI is not without any drawback since you have other side effects as well. And now let's take a look at the comparison in between H2 antagonists versus PPIs. So H2 antagonists is cheap and effective, but they can induce thrombocytopenia and arrhythmia. And it also has a short acting lifespan. PPI on the other hand is highly effective and it can last for a long term of up to 1 to 3 days. But with the use of PPIs, pH can increase, therefore you will get indigestion leading to nutrient deficiency. At the same time, there's an increased risk of getting infection with C. difficile as the pH is not so acidic. And this drug is a slow-acting drug as compared to the H2 antagonist. To inhibit gastric acid production, these are the drugs that we can consider. The first one is muscarinic acetylcholine receptor antagonist, and it works by blocking your acetylcholine receptor. Then you have the H2 receptor antagonist, but now PPI or the proton pump inhibitors have become the first line therapy in treating peptic ulcer. And now let's take a look at the H2 antagonist with more details. Because they can bind to the H2 receptor, these drugs actually act as a competitive inhibitor for histamine. And with the use of H2 antagonists, acid production is reduced by 90%, and that promotes healing of the peptic ulcer. So two examples of the H2 antagonists are ranitidine and cimetidine. And because H2 receptors also play an important role in cardiac stimulation, the use of H2 antagonists can lead to cardiac side effects such as irregular heartbeat. And for this reason, PPI is preferred. If you look at the pathway of gastric acid production, you could see many more potential drug targets such as the G cell, the ECL cell, and the parietal cell. They are all essential in the control of gastric production. G cell secretes gastrin, which binds to the CCK2 receptor, triggering the release of histamine. And where will histamine bind to? Well, the H2 receptor on the parietal cell. So this increases CAMP level and subsequently switching on the proton pump. So the most direct strategy would be taking the PPIs or the proton pump inhibitors. But you can also take atropine, which will bind to the muscarinic receptor M3R, and it is required in gastric secretion. So with atropine, it antagonizes the effect of M3R, and therefore you will get less gastric secretion. So we've talked about the H2 blockers or the H2 antagonists, which basically block your H2 receptor, and with that your histamine cannot bind to this receptor, therefore reducing gastric production. And your stomach naturally produces prostaglandin or PGE2 that protects your cells from the acid. So PGE2 works by binding onto the EP23 receptor, inhibiting ECL activity. So misoprostol is an artificial prostaglandin that has the same effect as PGE2, which reduces ECL activity and subsequently less acid production. And what happens to you when you take the NSAIDs or the non-steroidal anti-inflammatory drugs? Well, they inhibit your COX-1 enzyme that is required in the making of prostaglandin PGE2. And for that reason, with the overuse of NSAIDs, that could lead to some stomach discomfort. Proglumide, on the other hand, when bound to the CCK2 receptor, inhibits ECL activity. Again, that reduces gastric production. Now, cimetidine is a H2 blocker. So you can see that with the use of cimetidine, you have reduced gastric production, while betazole is a histamine analog, which stimulates gastric secretion. But when you take betazole together with cimetidine, you still have a suppressed gastric production. Now you could see that in the second experiment, how the presence of cimetidine actually reduces the production of pepsin. So pepsin is an enzyme required in the breaking down of protein, but with the use of cimetidine, you have less pepsin level, which means sometimes with the use of cimetidine or with the use of some other H2 blockers, that could lead to indigestion issues such as diarrhea. To summarize, histamines play important roles in both the allergic response and gastric secretion. Drugs that can bind to the histamine receptors can be used to block the action of histamines.